Advanced cardiac life support, or ACLS, is a structured way to respond to an unresponsive person with cardiac arrhythmias and cardiac arrest. ACLS can be done by an individual or by a team that's led by a team leader. When we suspect a person may be in need of assistance, the first thing we need to do is determine their level of consciousness. Talk loudly at them, rub their sternum, or apply pressure to their nail beds or earlobes, while simultaneously checking for absent or abnormal breathing. If they're not responsive, check their carotid pulse for about 10 seconds. If there's no pulse, first immediately activate the emergency response system to get more help and an AED or defibrillator. Then move on to the ACLS algorithm. The first thing to do is cardiopulmonary resuscitation, or CPR, which combines chest compressions and artificial ventilation. The big picture goal of CPR is to maintain blood flow to the brain while a patient is pulseless. Because the patient's heart is not functioning, the team is mechanically squeezing the heart to ensure blood flows to the brain. In a person over 8 years of age, chest compressions are done by placing the heel of one hand in the center of the chest, then placing the other hand on top, interlocking the fingers, and without flexing the elbows, pushing down on the chest. This should be done to a depth of at least 5 centimeters or 2 inches, which is about the same size as a closed fist is lengthwise. Compressions are done at a rate of about 100 compressions per minute, which you can remember if you do them to the beat of "Stayin' Alive" by the Bee Gees. Additionally, the team attempts to artificially ventilate the patient so oxygen can enter the lungs and carbon dioxide can leave. Artificial ventilation includes a variety of ways to assist respiration for a person who isn't breathing or making sufficient respiratory effort on their own. The options for ventilation usually involve a bag valve mask device to push air in. A bag valve mask can be applied directly to the person's mouth or with an oral airway, a supraglottic airway, like a laryngeal mask airway or LMA, or an endotracheal tube. Directly applying the bag valve mask is the simplest option, since it's just positioned over the nose and mouth of the patient, creating a tight seal so air does not escape around the sides of the mask. If the bag valve mask is ineffective or difficult to perform, like in the case of an air leak because of an abnormally large face, then a supraglottic airway can be placed blindly into the airway through the mouth by pushing towards the throat. This is generally preferred over endotracheal tube intubation because it's faster to perform and minimizes the interruption of chest compressions. Time and time again, researchers have shown that the most important part of ACLS is high-quality, uninterrupted chest compressions, followed by defibrillation in those who need it. That's why intubation is done only if the patient can't be ventilated by other means. Continuous capnography should be performed in addition to clinical assessment for both confirming and monitoring correct tracheal tube placement, and for monitoring the quality of CPR and the return of spontaneous circulation. Capnography is a recording of the amount of expired carbon dioxide coming out of the tube. When ventilating a patient in cardiac arrest, 100% oxygen should be used. In a person over 8 years of age, the rate of compressions and breaths should be 30 to 2 for both single and two-person CPR. Finally, it's important to have access with an intravenous IV line or interosseous IO line in place as soon as possible so that it's ready in case you need to start giving medications. Compressions and ventilation are started immediately on patients without a pulse. However, as soon as an AED or cardiac monitor or defibrillator is available, using it becomes the most important step. The ACLS team needs to troubleshoot the non-functioning heart by diagnosing the cardiac rhythm and defibrillating if indicated. Chest compressions should be paused briefly to apply and use the AED or cardiac monitor. This allows accurate assessment of the rhythm on the ECG and determines whether it's a shockable rhythm, like ventricular fibrillation or VFib, and pulseless ventricular tachycardia, or VT, as well as a non-shockable rhythm like asystole and pulseless electrical activity, or PEA. In ACLS, ECG interpretation is guided by 3 questions. Is the rhythm fast or slow? Are the QRS complexes wide or narrow? And is the rhythm regular or irregular? Rhythms where a defibrillator can be used to shock a patient, shockable rhythms, are ones that are fast and have a wide QRS complex. After that, VT is a regular rhythm, whereas VFib is an irregular rhythm. If either VT or VFib is found, defibrillation should be done as soon as possible. Defibrillation with a synchronized shock is given when there's a regular rhythm, like in VT, whereas an unsynchronized shock is given when there's no regular rhythm, like in VFib. The initial dose of energy that the defibrillator delivers typically ranges between 120 to 200 joules, but a maximum dose can always be used even on the first attempt. Immediately after delivering the shock, chest compressions must be resumed right away without reassessing the rhythm. After 2 minutes of chest compressions, there's a new evaluation of the rhythm through ECG. If the rhythm is still shockable, a second shock is given using the maximum available dose of energy. In addition, 1 milligram of epinephrine is given using the IV line. All medications should be followed by a saline flush or by raising the patient's arm to guarantee that the medication travels all the way to the heart. Once we start using epinephrine, it's continuously given every 3 to 5 minutes while chest compressions are being performed. After 2 minutes of chest compressions, or when there's a rotation of the person doing CPR, the rhythm is checked again. The rhythm is still shockable after a third defibrillation attempt. 300 milligrams of amiodarone may be administered intravenously as well, with a repeat dose of 150 milligrams IV as indicated. If amiodarone is unavailable, it may be replaced by 1 to 1.5 milligrams per kilogram of lidocaine given every 5 to 10 minutes. Additionally, 2 grams of magnesium sulfate, followed by a maintenance infusion of 1 to 2 grams per hour, may be used in case of polymorphic ventricular tachycardia, consistent with Dorsade de Pointe, but it's not recommended for routine use in ACLS. This whole process is repeated for however long it's needed. There's no absolute standard. Generally, it's interrupted if there's a clinical change in the patient, like breathing or regaining consciousness. Alternatively, it may be stopped if it looks like a patient won't survive, like after 30 minutes of unsuccessful resuscitative effort, or in patients with an end-tidal CO2 below 10 millimeters of mercury. That's because a low end-tidal CO2 following prolonged resuscitation, so over 20 minutes, is a sign of absent circulation and a strong predictor of death. End-tidal CO2 values are a function of carbon dioxide production and venous return to the right heart and pulmonary circulation. This is evaluated through capnography. Now, moving on to non-shockable rhythms, the most frequent one is asystole, which is where there's a complete absence of electrical and mechanical cardiac activity. The other one is pulseless electrical activity, or PEA, which is a mix of electrocardiographic rhythms, which result in insufficient mechanical contraction of the heart to produce a palpable pulse or measurable blood pressure. PEA can be associated with any electrocardiographic rhythm, and actually sinus rhythm is the most frequent type of PEA. Once a shockable rhythm is diagnosed, 1 milligram of epinephrine is given right away, and then given every 3 to 5 minutes while CPR is performed. After 2 minutes of CPR, the cardiac rhythm is reassessed. If it becomes shockable, defibrillation may be done. Otherwise, CPR must be resumed for 2 minutes, and then the rhythm is reassessed. This is repeated for however long it's needed. If a patient improves with ACLS, the immediate post-cardiac arrest treatment includes an assessment using the ABCD approach. That stands for airways, checking if they're clear, breathing, looking for signs of respiratory distress, circulation, evaluating tissue perfusion and signs of bleeding, disability, using the Glasgow Coma Scale, and exposure, or examination, by doing a head-to-toe assessment and getting the clinical history. Any additional treatable underlying causes should be identified and managed as quickly as possible. These include hypoxia, metabolic disorders, poisoning, hypovolemia, hypothermia, tension pneumothorax, cardiac tamponade, and cardiac or pulmonary thrombosis. Alright, as a quick recap. In an unconscious patient, first you check for a pulse. In a pulseless patient, you try to see if the patient speaks or moves. Then you check breathing. ACLS begins in patients that are unresponsive and not breathing normally. Resuscitation begins with chest compressions, attaching the defibrillator, placing monitors and IV lines, and obtaining the ECG. The ECG analysis will show either a shockable rhythm, like ventricular fibrillation and pulseless ventricular tachycardia, or non-shockable rhythm, like asystole and pulseless electrical activity. A shockable rhythm should get defibrillated as soon as possible, with IV medications given each round. In a non-shockable rhythm, epinephrine is given right away while CPR is performed. ACLS is repeated for however long it's needed.